Brenda, could you describe the clinician's role in Families Plus?
The clinicians have a very challenging role in Families Plus, but rather exciting because they are working with children with complex needs, of course, and these children have been through adverse events. They've been through trauma. The families are in stress a lot. And rather than bring the child or the family into their office in a 1-hour confined setting, they go where the child and family are. So they're working in a clinical way with the child and family in their home setting, in their school setting, in their neighborhood. They're working with them in those settings. So they have a chance to use their skills and to move in and do therapeutic conversations in the moment when things are going wrong and when things are happening. They're there. So they are very challenged sometimes, but they are really developing high levels of skills for intervening and helping families move through problems.
So they're working in lots of different settings.
They're working in lots of settings, and there's been a concern as we grow that our office will be too small, and I've thought, well, they're not in the office very much.
Yeah. Right,
So, the design of the program is to be out where families are and to be meeting their challenges alongside of them, rather than 2 weeks later when a family can get an appointment to hearing about what happened. So they're often on the scene.
Sure. I noticed that you've formed your overall program model in parallel with the wraparound process. Can you describe why you did that?
Our model evolved very naturally, trying to serve these types of families in a way that was comfortable for them. Mm-hmm. So it just naturally came around that we should meet them where they are instead of expect them to come where we are. So we go out and we form a comfortable relationship with them. We're able to, we can go out in our jeans and t-shirt and we talk to them and we listen, and we especially listen to what they want for their children and where they're going with their family and what their problems are. And as we move along, we help them form an idea of where they're going and what they need. So that's is that very similar to wraparound?
Yeah, and I think one of the questions we have with wraparound is, what does this child and family need to have a better life? So if it's dental care, okay, let's go with dental care. If it's a job, let's help them get a job. It's sort of whatever it takes. And it sounds like that's your approach to the families.
That's how we've always settled in, is like, we're here to work alongside of you and help you. So where do you want to go for this child? We focus on the child. Yeah. What do you want for your child and what's in the way?
Sure.
So we do that, and then the families are so stressed often that they get discouraged and they think they can't do it. So a big part of what we do is help the parents understand you have many things to offer your child that no one else can offer, particularly your love. There's nobody else like you for your child. So we help them understand their strengths and how important they are, and to help them believe that they can raise their child to be self-sufficient and successful.
Yeah. And I just love that, because honestly, for so many parents, they've been beaten down, they've been blamed and shamed, perhaps even by professionals who look at them and say, wow, these are really multi-problem parents. But they have really wonderful things about their parenting. Plus, they're the experts on the kid. So. And
we have this strong feeling when we're in relationship with families and we know them well. We think to ourselves, if I had all these things to deal with at the same time, I don't know if I could do as well as this family is doing, because the challenges are mind-boggling.
Yeah. They must respond well to that, because I've found over the years with wraparound that families find it incredibly refreshing.
Our families really appreciate that somebody listens to them and understands they're not just a slacker. They really have too many things to do.
Sure. Oh, that's so neat. On a different tack, I've noticed that you've started to put clinicians in physicians' offices. Can you tell me why you've done that?
Well, it's a little out of line with what we've been doing for many years, but we're trying to think forward and build a model that will work, a model that will work in the future. And our sense of the healthcare world of the future is physical and behavioral healthcare will be very integrated. So we thought if we could work on delivering care to children with complex needs in the doctor's office, that's what we need to know how to do, to start from that base. We often have started from the schools referring and us getting involved, but we would like to get into the medical world, have the doctor refer and get us involved there so that we're integrated with the physical and behavioral health, because our kids' health, physical health, is likely to go downhill as they grow up because their parents' health is not very good. They have poor social determinants of health, so we want to be there in the healthcare world, integrating it. And then, as part of the package, we agreed to also provide behavioral health care to other adults and children that the physicians are working with.
And that's exciting because it's really clear that's where we're moving. You know, we've always separated health and behavioral health. It's like almost like we're two different organisms, two different people. But the reality is it's all together. I was reading an article today from the Substance Abuse and Mental Health Services Administration, you know, really just pushing this notion of integration. And yet, integration is kind of tough to do at times. How has it been sort of meshing the health world and the behavioral health world these last few months of this effort?
We're about 6 months into this, and let me tell you, it's two different cultures and it's two different worlds,
Right.
and we can see it's going to take a lot of time. Even though everyone is very into it and enthusiastic, we have different languages, we think
Sure.
differently, and we don't understand each other very well. And the whole idea of paying attention to the social determinants of future health
Sure.
is kind of new to a lot of us,
Sure.
but that's what we think the Complex Kids model is doing, is trying to eliminate all the determinants that are going to make these children unhealthy as adults.
Sure.
And so there's a lot of conversations that must happen before we really, we're on a team together, but before we're really on the same view together.
Sure.
Lot of work here.
What do the MDs think of this?
We don't think this is true everywhere, but here in Delta County, our medical providers want behavioral professionals alongside of them. They really appreciate it. They really want someone to handle a patient in crisis. They really want someone to move forward with depression treatment. They really want it, but our worlds are so different that we have a ways to go for it to be smooth.
Sure, sure. Well, you're to be given a lot of credit for trying this out. You know, one of the things we know about rural America, you and I both live in this little tiny county here in western Colorado, is that often the stigma of going to see a psychologist or going to see a therapist is pretty high. Do you think this helps cut that stigma?
I think it helps immensely to cut the stigma,
sure.
because the stigma isn't going to evaporate anytime
right.
soon, but people tend to trust their physician. And when the physician says, you know, you are really having a hard time with your mood, and I have someone right here that can help you today, it works.
Sure,
People
sure.
go into the behavioral health office, they get some support, they engage, and it goes forward. Whereas in the old days, they would say, here's a phone number, call them. They might call you back in a few days, and they don't call half the time. They just don't.
It just seems so much more friendly. You know, it just seems like a much better way to do this. Because families are, you know, they're often embarrassed. They feel bad over what's going on. You know, say the family's going through a divorce and the kid's not sleeping at night. This kind of opens up an easy path into getting help for some of those things. I love it. I love it.
Yeah, and a lot of people are really moving right smoothly into it, and they feel supported by both their behavioral professional and their physician, and that all are understanding the whole dimension of what they're facing.
Yeah, yeah. Well, speaking of integration, one of the things that we talk about, integration is clearly where human services, behavioral health, juvenile justice, child welfare, housing, drug and alcohol services, corrections, we know our families have needs that cut across lots of those areas. And yet, traditionally, in big cities and little cities and all over America, these systems don't work together very well. They don't play well together. How do you get this aspect of this dealt with? I mean, how do you get the system to come together and work together around this one family? Because I know, you know, rural people don't have a lot of tolerance for silliness, and having multiple plans for one family is kind of silly. How do you do that? How do you bring that system together?
We approach it just like we approach working with their families on a very much relationship basis. You know, because we're a fairly small area, our therapists form relationships with caseworkers and with teachers and educators and juvenile justice, probation officers. We have relationships that have been going on for a number of years, so that's how we bridge it. There are still the different viewpoints and the different rules and the cookie cutter things everybody has to do, but because we know the people and they know us, we often can pull it together and help the family advocate for themselves about, yes, this will help me, but that won't. So we often can get some distance in that way. Where, you know, there's definitely, of course, a lot of silos and a lot of barriers to working together, but we think we can bridge it in a small community through relationship.
Yeah, and I've always found that in a smaller community, in a more rural area, that when things work, people also talk to each other about it working. You know, hey, this kid was, you know, on my probation caseload and problems were really tough and he was blowing it at school, but wraparound helped bring this everybody together around getting better outcomes for this kid.
No, we've had cases like that where juvenile justice has been reluctant to send kids home, and we're saying, no, they can do it. And then they go home and do beautifully, and everyone is very happy together because it worked.
Sure.
You know, their program worked and our program worked after it.
Brenda, we know that the world has changed from when I was trained, and perhaps even from when you were trained, that clearly evidence-based practices are a major focus of what we do. How do your clinicians integrate evidence-based practices into their overall sort of gestalt of what they're doing with the family?
We, of course, have a lot of trauma. So we do a lot of trauma-focused CBT. But that we do in our clinic. We have a playroom and we have a clinic setting that we can use when that's needed. Good. And we do a lot of motivational interviewing. That's just a style that we have to adopt. So we are really trying to pull those practices in and provide some actual brief evidence-based treatments to kids who have acute problems that they need to cope and learn and move through. So we do acute treatment, but we also do systems of care treatment.
Okay. Can you just give us a sense of which children and families are eligible for Families Plus?
We think that we have something really important to provide to families who have very low resources and very high demands.
Sure.
And to make that more concrete, we have a list of criteria we use when we're evaluating families who want to join our program. And we first look that the children have some level of behavioral health need, and we look to see if the family already has a extended family and a good support system. They don't really need us. We look for families, often single parent families without much, healthy support, and we look for families that are in very big poverty, because the pressures and demands of that personal situation overwhelms the parents and they're not able to provide. So we look for that. We look for parents who have their own physical or health problems. I mean, parents who have seizures, or parents that have major depression that doesn't remit, parents that have their own health problems that really compromise their ability to provide everything that is needed. That kind of family, we look for families, or they look for us, grandparents who all of a sudden wake up one morning and they have 3 children to raise and are very overwhelmed. And they look for us. It's like, oh, please help me. I don't know that I can really do this again. Those families come in, and we also have a number of families who have children with early chronic mental health conditions, where the family has plenty of resources, but they don't have resources to deal with something like that, and they need help over a long period of time to guide their children to health.
Yeah. My experience with those types of families is they often bounce from referral to referral to referral to referral as these kids get older and older, never really getting any help. So it sounds like it's almost they can come in and have a really wide view of their overall problems and concerns and be able to move forward with you. That's That's pretty neat stuff. Brenda, I've trained wraparound for 30 years, more frequent flyer miles than anyone you've ever met. But
Including training me in Montana many years ago.
Okay, a long time ago, right? When we were kids,
Yeah.
right? But the reality is that I've been all over the country, all over the world, training wraparound, and I've never seen where a program like yours integrated mentors in the way you do. Let's talk about those mentors a little bit. Could you tell me sort of how the mentors work and how they fit into the whole program?
Mentors in our program are very specialized. We are most excited about our mentors because our mentors are mentoring families. They're not usually a single person.
Right.
They're a family that has several of their own children in the home, or they're an empty nest couple that has children but their children are not in the home. They're families. And we think this is the most powerful thing we have to offer kids. The children, one child is invited regularly into the mentoring family. We want them to just go there and hang out and be comfortable and feel free to go get a glass of milk out of the refrigerator. We want the child to feel like they are part of the family. We just love it when the family has a family reunion and everybody comes home and the mentored child is right in the middle of all that, seeing the connections of family. And we think that's powerful because the children, without anybody giving them a lesson or making any effort, they learn. They model conflict resolution. They model routine. They model everything they see this family doing. And it's a little blueprint in their head that they will always have to take forward with them. They learn self-sufficiency. They learn to be responsible and take accountability. They learn all those things just by being present as all that's going on around them. So it's really a powerful influence on these children.
And I one of the things that we know from human services is services are often very time limited and brief. Mm-hmm. But it sounds like mentors can maintain a long-term relationship with these kids and with these families.
Oh, definitely.
Yeah.
We're trying to form permanent relationships, and we are. Wow. When we started out, I was sort of hesitant to say to the signing up mentoring family, well, we want you to just really commit for life. But then I realized as we were a couple, 2-3 years into it, people who care about kids and want to get involved with kids, they don't want you to say, okay, time's up, you're gone. It's just what they want to do. They do want relationships that last, and these, by and large, last. And so relationships are strong, and the kids feel important to their mentoring families, and they are. And the mentoring families are somewhat like the canary in the coal mine, because these mentoring families are very tuned into these kids, and if something is really wrong, oftentimes they're the first one to notice something's wrong. They call the behavioral health professional and say, they're not right, what's wrong? They really know when the kids are in trouble.
How do the clinicians interact with the mentoring or the mentoring families?
They are expected to have several contacts a month to support them and to help them negotiate and maneuver things and help them. There's a real cultural difference. We have children from poverty. We have middle and upper middle class families. They don't always understand what the kids talk about and what's going on. So the therapists support them.
You told me a while back that you really prefer that the mentors, they know the family, but they're not really working with the family. They're really working more with the child. Why is that?
Well, partly it's for the parents. They just need a break. They need their child to be somewhere else sometimes where they don't have to worry about him one little bit. So it's to just give the parents a break. And then it also helps the mentoring families, because if they get involved in the other children in the family and the challenges of the family, it wears them out. It's just too much for them. If they can put all their energy into one child and their little stumbles that they have going on, focus there, that's what we try to get them to do. And we ask them to call the behavioral health professional if they think there's a problem needing addressing, and let the program address it, not them. It's not that we want to ignore things, it's just they are so precious and they're just so important that we don't want to wear them out.
Are you able to get enough mentors?
We find people really interested in mentoring. We do.
Yeah.
And, you know, I just talked with someone at the bank, small community, who
Yeah.
was going to meet their mentor child on Saturday, who was so excited they almost couldn't sit in their chair.
Oh, that's so neat, yeah.
Because children are wonderful, you
Yeah.
know, and these children are as wonderful or more
Sure,
than anybody
sure,
else's children, and they are really enjoyed by their mentoring families.
Yeah. I noticed when we were talking a while back about outcome data that overall over the last decade you've really been able to find mentors in adequate numbers.
We can find mentors, yeah.
You bet.
Yeah. Sometimes our program gets overwhelmed with demands and doesn't get out there and look, but if we're out there looking, we can find mentors.
Wow. And that's so nice about a rural area, being able to think that way. But my heart says big cities, you could do that too with the right approach.
I think you could.
Yeah,
I think
absolutely.
you could, because I think it's the appeal of children.
Brenda, can you tell us about some of the outcomes over the last decade?
We are, in general, really pleased with how the children who are persisting in our program are coming along. Because these children have almost all been through adverse childhood events, they've had trauma, they've been evicted, they've gone through things, one would expect that when they hit middle school, they would start to smoke pot and get in trouble with the law and quit doing their homework, and that's what one would expect to happen. And in high school, probably even worse things. We would expect them to just plain drop out of school and quit. That's what is often happening. But that's not really what's happening with these children. We've had 101 children in our program in the last 10 years, and we've only had 2 that left school without a diploma.
Wow.
We've only had...
And that's amazing. That's
only
that's
2,
just amazing.
yeah.
Wow.
And we really work hard on keeping them engaged in education. And we've only had 3 that have gone into the juvenile justice system in that time. We've had 8 who have been, at least for a little while, in foster care and come back. And we've had 3 that have been in long-term residential mental health treatment, and we've had 3 that have been in short-term mental health treatment. But that's a lot of kids, and it's a lot of time. So we've had pretty low levels of out-of-home placement.
Yeah, that's pretty amazing data, absolutely. What about some of your other data?
Well, we are a mental health specialty clinic, so of course we're really interested in the mental health of these children. So we have the Achenbach Child Behavior Checklist that we give through parents and through teachers and through the youth when they're 11 every year. So some of our kids have years of data to follow. And other measures like depression inventories and grades. We have a whole set of data. But last year we took the teacher Achenbachs and we discovered that 79% of the kids had improved from their beginning score on the child behavior checklist or were in an adequate range. And with the parent measures, we found that 69% of the children were improved or were in an adequate range of behavioral health.
Right.
So we were quite pleased with that, considering the expectation is downhill, not uphill.
Sure. And I know from being able to have met Dr. Achenbach and worked with him that, you know, one of the things he often has said is that without services, without support, kids with really complex needs don't just get better as teenagers. Things get a lot worse. And are you finding that?
We're not finding that. Of course, not every child is on a perfect track.
Sure.
And we know the pitfalls, and we're just trying to help steer the children and help the families know how to steer their children around them, and we're having a fair amount of success with that.
So just even the notion of you've only had a few kids not get a diploma, to me, that says these kids are getting better. They're not getting worse. So they're on an upward trajectory. So that's really exciting. Brenda, what's next for Families Plus?
Families Plus is at a really exciting point. We have expanded out to having soon 3 full-time therapists and other therapists in addition. So, and our model is getting pretty well defined, but we need to now craft a really good treatment manual and develop some good training materials because we know how to implement it here, but we don't know how to explain it. We don't know how to
Yeah.
teach it.
Sure.
So we really need to be working on that. We would love to extend our research to real outcome research. We
Sure.
have some good ideas for better, solid outcome research, and we'd love to implement that as soon as
Some
we
more
can.
controlled studies.
Yeah,
Okay.
match group studies
Sure,
or single
sure.
subject studies, more
Yeah,
sophisticated
yeah.
research, we need to move in that direction. And then we're really excited to be able to share this with other communities who are really concerned about their youth and see them dropping off as they hit middle school and high school. We would love to help other communities do this.
Sure. I think the demand across rural America for a model like this is certainly high. Do you anticipate sort of presenting at conferences and getting out there and sharing this information, or have you done that already?
Yeah, no, we're beginning to publish. We have
Okay.
some manuscripts
Okay.
submitted, and we have some conferences
Okay.
booked. So we are starting to be able to talk about this because we are excited about it, and we think other people will be excited about it.
Yeah, and that's exciting. I think just the need is so great. It would really be helpful. So, all
And the
right.
fact that it can help even 10 kids is exciting because
You
these
bet.
kids can go through a lot of misery without some help.
You bet. You bet. Well, thank you.
Thank you.